Professor Mary McCarron, and to all of us, she needs no introduction. She has been a major central player in DOCTRID in the past 5 or 6 events. But Professor McCarron is Chair of Ageing and Intellectual Disability at Trinity College Dublin, and she's Director of the Trinity Centre for Ageing and Intellectual Disability. Now, she's played many, many roles, but I think we all know her as the Dean of the Faculty of Health Sciences, with leadership and budget responsibilities for the schools of nursing and midwifery, pharmacy and pharmaceutical sciences, dental science, medicine, and therapies. And I could go on for this, but I think you can all read the biographies in the session. So, without any further ado, Mary, I would like to invite you to bring you and your colleagues up and start us off with Session 1, Aging, Health, and Wellbeing.
Thank you very much. Thank you, Ian. It's a great pleasure for me to be here, and I want to thank the organisers. And I obviously have been very involved all of my life, indeed, with the Daughters of Charity, and it's a great pleasure for me to support the initiative of Respect. And I thank Sister Zoe, who I've known a very long time and worked with for quite a period. I'm going to give a keynote this morning talking really about longitudinal studies and what they're telling us around ageing. And I think while ageing is going first, I think how we live our life as young people really defines how we are as we age. So it probably is good to have the ageing session at the end, because everything that I'm talking about needs to be addressed at the children's end in order to age well. So I think that's important. I do want to introduce my colleagues, Pamela Dunn, who's a clinical nurse specialist in dementia at the Daughters of Charity Service, and has done fantastic work. I think the Daughters are leading really what is now recognised as a world-class service when it comes to both diagnostics and post-diagnostic supports of people with dementia, and I'll speak a little bit about that later. I also want to introduce Dr. Niamh Mulryan. Niamh is the clinical director at the Daughters of Charity Service, has made a huge impact, has worked very closely with me at Trinity College, as indeed Pamela and the community of the Daughters, in really trying to address critical issues around ageing. So I'm going to, both of them will do a shorter presentation, and we'll see how all of this works. Perfect, thank you, Greta. Around 2 longitudinal studies, one of them at the IDS Tilda study, and another longitudinal study which has happened at the Daughters and continues to happen at the Daughters of Charity Service. So just for people who are not familiar with what the global family of longitudinal studies, many of you will be familiar with TILDA, the Irish Longitudinal Study in Ageing. And TILDA, of course, similar to all countries in the world, has been built from the Health and Retirement Study in the US, the HRS. And from that, many longitudinal studies emerged all over the world. And on this map here, you can see the dots of all the countries now that are involved in longitudinal studies. When Ireland was launching TILDA back in 2006, 2007, you had somebody like me knocking at the door of the ministers saying, how come no other country in the world has ever included people with an intellectual disability in a longitudinal study in ageing? And I had a lot of naysayers at the time who felt it wouldn't be possible to include people with an intellectual disability in a study of this nature, that the protocol would be much too long, the consent issues would be really crippling, we wouldn't get the funding, etc., etc. 10 years on, we have celebrated the 10th anniversary of IDS Tilda, and we have had a 96% retention rate over the 10 years of IDS Tilda. And we are following 10% of the population of people with intellectual disability in Ireland. And this sample has been randomly drawn in Ireland for people from outside Ireland. We have what's called the National Intellectual Disability Database. And from that, I was able to get permission to randomly select 10% of the intellectual disability cohort. And we are following them throughout Ireland for the last 10 years, using the same outcome measures as TILDA for the general population. So this is really exciting. the government have, after 10 years, have decided that they were going to continue funding IDS Tilda as a main source of data to underpin evidence-based policy making, particularly with respect to ageing. And this is the map of Ireland. You can see here we have had people selected from all over, and that is the number of the scientific reports across the cohort from 2007. We now are refreshing the sample, who will be again randomly drawn from the database. And because obviously those, we included people at 40, Tilda and the general ageing studies enroll people at 50. We included people at 40 because of premature ageing, particularly among those with Down syndrome. So obviously those aged 40 to 50 have aged out, and now we're refreshing primarily within that particular cohort. And the main objectives of the study is to understand the health characteristics of people ageing with an intellectual disability, to examine the service needs and healthcare utilisation of this population, and to identify the disparities in the health status of adults with an intellectual disability, and to compare that to the Tilda findings for the general population. So this is a unique opportunity that we're able to look at the determinants of health and well-being for people with an intellectual disability in their own right, and then compare those to the general population, which is a really unique opportunity, and to support evidence-based informed policies, practices and evaluation. And through this presentation this morning, I'm going to try to weave in how we are trying to impact on policy. We have had a very, very strong values framework which has underpinned the study from the very beginning. Many of you will recognise this lady, and that was one of inclusion. We worked very closely with people with intellectual disability. When I dreamt up about having a supplement, running a longitudinal study, I had no money. I had an idea, I had passion, I had wonderful people around me, and I had many people with intellectual disability. And I sent out a call to people with intellectual disability in Ireland to submit pictures of what ageing meant to them. And I asked them if they had consent to use them and to write a small narrative. And within a 2-week period, I got 240 photographs submitted with a narrative from people with intellectual disability all over Ireland. And we struck off around the country to the ploughing festivals, the fringe festivals, the Wexford Strawberry Festival, and we worked with people with intellectual disability in every part of Ireland to celebrate ageing. And we ramped up a coalition of support from and by people with intellectual disability themselves. And I think that was hugely important. And after that, I always say, if the idea is good enough, the money will come. And we had a very, very person-centred ethos, which people with intellectual disability were involved from the beginning. And this is some of our participants here. They're the patrons for people here, the patrons of our study. Maggie up in the corner here is now 92 years of age, and which is fantastic. And Chrissy is now in her 80s. And these two gentlemen here have since passed away due to Alzheimer's disease. And this is some of our participants here, even though we're using the same protocol as Tilda, because we need to compare. We also recognise that there were likely to be additional issues for people with an intellectual disability, and we held workshops and focus groups and used very innovative approaches to get their opinion and include additional measures. And this is us here celebrating our 10th anniversary with many of our participants at the university, and it was a great occasion. And at this time as well, we launched at the university the Trinity Centre for Ageing and Intellectual Disability. And any of you who work in the university sector will know that it's not easy sometimes to get institutes or centres launched within a university. But now that we have that infrastructure, I think it is hugely important for us going forward. So as I said now, the government have continued to fund this, and hopefully it will live well beyond me over hopefully the next 10 years. This is the conceptual framework which has underpinned the study. I'm not going to read it out. You can see it for yourselves, and there will be a copy of these slides available. But you can see it's a very, 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 very vast amount of information that we are collecting. And the areas that are coloured in are unique areas that we included for people with intellectual disability. We included a whole domain around social, particularly around community, connectedness, social connectedness, friendships and transitions. I have a massive team of people working with me now because this is very, very broad with mounds of data, and we just need more and more people to help us to understand it. In wave 4, we're including, which we're getting ready to go out into the field. There is now, at this moment in time, 23 field workers who have just undertaken a very intensive 3-day training in the last few weeks, heading out into the field. And now we're interviewing on Monday for research nurses to actually now run the health fair. Unlike Tilda, we were not able to go to a large company like Ipsos Mori and go out and interview large people. We had to have people with very specific experience in people with ID because we really wanted them to be able to engage and help people to participate. And they are some of the measures now that we will be using in the health fair for this particular wave. I'm just going to give you a little flavour of some of the findings that have come through over the 10 years. So when you look at chronic and the prevalence of chronic health conditions, and there's some things here that are different, some which are worrying, and some which are really intriguing to understand more about. Very high prevalence over the 10-year of chronic constipation in this population, increasing to over 40% over the 10 years. We asked people, this was the same as Tilda, have you ever been diagnosed by your doctor with X disease? And similar to any longitudinal study, even though we as researchers and academics don't like to think that there's an intervention as part of any study, but when you ask people multiple times, have you had this test or that test, it often encourages people to go and be screened. But you can see here, doctors' diagnosis of osteoporosis increased, as did arthritis, very high level of emotional and psychiatric conditions, with over 50% of the population reporting a mental health problem. And I'm really privileged to have the like of Dr. Niamh Mulryan and her team who's leading out on the mental health arm, because we really need these to be discipline specific, and that is really important. You can see here as well the very high prevalence of epilepsy in people with intellectual disability. How do people age who have lifelong epilepsy? We don't really know. 30% of the population have epilepsy. This compares to about 1% in the general population. The new incidence of epilepsy that we see here is very much driven by new onset Alzheimer's disease in people with Down syndrome, where we see a prevalence of new onset seizures in people with Down syndrome when they develop Alzheimer's disease of about 80%. The prevalence of new onset seizures in the general population who develop Alzheimer's disease is about 11%. So there's something very different happening. And this here just gives you an idea here, as I'm quite concerned in terms of chronic constipation. And you see here a 43% prevalence in this population over the 10-year period. And what's really interesting here is that level of intellectual disability and mobility were significantly associated with constipation when age wasn't. Whereas in the general population, you very much see this as being an age-related issue, but it isn't for this population. And what's also concerning is that 42% of people with intellectual disability who are suffering from chronic constipation were on laxatives, with 40% of people on laxatives using 2 or more laxatives. And this is really, really concerning because we know factors associated with laxative use include anticholinergic burden and soft and liquidized fluid intake. And there's an opportunity here for a bowel intervention programme, and this is something that I'm going to work to pilot with the Daughters of Charity in one part of the organisation to look at what this intervention programme might look like. When it comes to oral health, I think this is a very important issue, and somebody asked me about this last night. We found that 28% of older adults with an intellectual disability in Ireland reported that they had no teeth at all. This compared to 16.9% in the general population, but what was really interesting and different here was those with no teeth at all, 68% of them with total tooth loss did not receive prosthetic dentures. So they were actually orally disabled. and this compared to 5.3% in the general population. And we know that those who had no teeth at all were twice as likely to have a difficulty with eating, 3 times more likely to be on a soft and liquidized diet, and twice as more likely to have chronic constipation. We're working very closely with the School of Dental Science. Professor June Nunn and Kevo Kivon are leading out on the oral health arm and doing fantastic work. There is numerous papers that have been published. You can download them from the site on every aspect that I'm speaking about. I was travelling last Christmas, and I was contacted by somebody in the UK government to give a comment on what was then a headline in a paper, where this lady, Rachel Johnson, unfortunately died after having all her teeth removed at the one time in the NHS. And I know we might look and we might think that's a horrifying story, but let's rest assured that probably isn't unique. And we do know that people with intellectual disability are much more likely to have extractions than they are to have restoration. And I think this is a real issue. We also have developed, the School of Dental Science have developed a website called brushmyteeth.ie, and this is a website geared to show people how to brush their teeth, and I would really encourage you to go in and to look at that. It's extremely good, depending on the level of support that people will require. When it comes to bone health, one of the reasons in wave 1, we usually have the objective measures at the health fair driven by data that we receive in a previous wave. In wave 1, when we asked people if they had a doctor's diagnosis of poor bone health, 8% reported that they had, 16% reported that they had in wave 2, and 21% reported that they had in wave 3. But what I'm really trying to get is to get under the bonnet as to why we see such a high prevalence of mental health problems in this population at over 50%. Now, when we ask people about pain and if they experience pain, many men reported that they had pain in their feet, they had pain in their back, and I think there's a lot of undiagnosed pain. So we decided then in wave 2, similar to what Tilda had done, that we would do an objective measure of bone health. Professor Ailish Burke did her PhD in this area and is leading out in this area along with Professor Bernard Walsh, a geriatrician from St James's Hospital. And you can see here, this is the card. So if we find measures or at the health assessment that are unusual or concerning, we will give each participant this card to take to their doctor or to take back to their carer. When we measured bone density using the quantitative field ultrasound scanner at the next wave, what we found was that 41% of the population met criteria for osteoporosis and that 33% met criteria for osteopenia. So we had over 70% of this population with poor bone health. And many of them did not know it, so it really posed the question how many of this population are walking around with things like vertebral fractures, undiagnosed pain, etc. There are multiple reasons that this population are predisposed to conditions like osteoporosis, including the very high levels of low physical activity, many of the medications that they're on, their diet, access to sunlight, etc., and that would be a whole talk in its own right. Nonetheless, this is a concern. Dr. Ailish Burke and the team at Trinity have been successful in getting an EIT Health Kick Award, and they have developed a massive online course to develop best practice when engaging with people with intellectual disability in health assessments. And this has been run now multiple times. It's a free MOOC, and I would encourage people to get on and have a look at what it is offering. I know that Natalia in her address spoke about physical activity and the problems that we have and the efforts that some of the Doctors' Fellows have been doing in terms to address this issue. What we found was that over 80% of the population really met criteria for overweight or obesity. Those with mild to moderate intellectual disability were more likely to be obese. Those living in community and living with family were more likely to be overweight and obese, and women were more likely to be overweight and obese. What we're actually finding is that women with mild to moderate intellectual disability who are living in the community appear to be having the worst outcomes. So this is a real issue. And I think what is important here is that 63% of those who are objectively measured as overweight or obese consider themselves to be the right weight. So we have a piece of work to do around this. While you can't outturn a bad diet, 86% of participants were sedentary or underactive. We're using now the ActiPal in wave 4 in the health assessment, where we will be using this ActiPal to attach, where we will be able to monitor very, very, really good physiological measures of levels of activity, but really we're interested in inactivity. How long do people spend sitting? And we have techniques in the next wave to look at that. We also, through the EIT Health Kick, have been working with Age and Opportunity. This has been run by Professor Marianne O'Donovan and Ailish at the Trinity Centre. And working with Age and Opportunity in the University of Barcelona, have developed a physical activity leadership programme. Which is really fantastic. So we have the Go for Life programme here in Ireland, which is really targeted at older people, but many people with an intellectual disability are not participating in that programme. So through this, we are building physical activity. Through this programme, we're building physical activity leaders, people with intellectual disability to be physical activity leaders in their own community. And we're very excited about that. We have just got significant funding through the EIT Health Call to run out this programme now at a national level. And Professor Marianne O'Donovan will really be working on that. So this is where we identify a problem as an issue in the data, and then we look at the translation and the intervention that needs to happen, like with the health assessments, like with the oral health, now with physical inactivity. But there are things that are different, and this is also interesting, despite things like cardiovascular disease and hypertension. So despite the higher rates and known risk factors for conditions like hypertension, people with ID have lower rates of hypertension. Now, we measured hypertension, the very same as TILDA, 4 measurements, and what we found was that 18.7% of the population had hypertension, and this compared to 40% in the general population. So the big question is why? What's driving hypertension? Here we had a population who we know are overweight, obese, inactive, had high cholesterol, and yet measured hypertension and stroke and cardiovascular disease and death from cardiovascular disease is way lower than the general population. So in this way, we are collecting, and there's a lot of issues around, is this related to stress? And would you agree? And this is a whole issue. So we perhaps have not understood the role, perhaps, that stress plays. And it's not that people with intellectual disability don't have stress in their life. They do. But perhaps it's a different type of stress. Many of this older cohort are not worrying about careers, mortgages, children, etc., etc. Many of the things, perhaps, that keep the rest of us awake at night. And maybe the stress is different. So we are looking, we're collecting hair samples in this wave, and we're going to measure cortisol over time and look really at stress. There's a huge amount of interest from the general population. What we have to understand is that people with an intellectual disability, and particularly people with Down syndrome, have been fundamental to our understanding of Alzheimer's disease. It was that population that really, and I really want to thank people with intellectual disability and those with Down syndrome, because they have contributed hugely to our understanding. I actually think they will now contribute hugely to our understanding of other chronic conditions, and particularly now looking at cardiovascular disease. So there's a lot of interest now from the cardiovascular community, as you can imagine, and we're working with colleagues at St James's Hospital, and Francis O'Brien and other colleagues at Trinity are leading out on this. Niamh, as I said, is leading out on the mental health concerns. And I said over 50% of the population had severe mental health diagnosis. It was a huge issue around, we are working with the School of Pharmacy and Pharmaceutical Science. Myra Dwyer and Professor Martin Henman are leading out on this arm. There is a number of papers published recently in the BMJ, and you can download those, really looking at medication issues. what we've seen here is we know that polypharmacy, non-polypharmacy if you're on 0 to 4 medications, polypharmacy is on, you're on 5 to 9 medications, and excess of polypharmacy is on if you're on greater than 10 medications. And what we found out that older adults with an intellectual disability, 72% of them were exposed to either polypharmacy, which is 5 to 9, or excessive polypharmacy, greater than 10 medications. And this compared to 27% in the general population who were meeting criteria for polypharmacy. I think the interesting thing is how these medications have ramped up over the years. And what's really concerning is the only decrease in medications that we've seen over the 10 years was in non-opioid analgesics, a drug category that you would have expected to see increasing rather than decreasing. So we have written a lot of papers on drug-drug interactions, on sedative burden, and we're now looking at, Myra is working hard now to try to introduce something like the stop-start criteria for this population. And these are the main drugs that's driving polypharmacy: the antipsychotics, the anti-epileptics, and yes, we have a very high percentage of people with epilepsy, so you would expect that, and laxatives. And as you can see here, how many are using 2 agents, how many are using 3 agents, etc. But you can also see the very different pattern of prescribing compared to the general population. We're not seeing, this is tilde, we're not seeing the lipid-modifying agents. We're not seeing the angiotensins. We're not seeing the antithrombolytic agents. So there's something very, very different happening in this population. And I think that's hugely, hugely interesting. I'm moving now to an area that's very close to my own heart, and that is that of Alzheimer's disease. We know that the prevalence of Alzheimer's disease in people with Down syndrome exceeds that of the general population, and they're at very high risk. Here in IDS tilde, we noted that you can see here the increase in dementia over the 10-year period, a mean age of about 52 years, and the mean age of dementia in the general population being with ID from other etiology appearing to be about 65 years. But what we see here from IDS tilde, we only asked if you had a doctor's diagnosis of Alzheimer's disease. We didn't do diagnostics ourselves. And of those with Down syndrome without a diagnosis, 47% never had an assessment. And yet we know that the international guidelines suggest that all people with Down syndrome over the age of 35 years should have an annual screen and should have assessment and workup for dementia. So there is an opportunity. So the biggest issue in Ireland and indeed in other countries has been lack of standardisation around assessment, lack of standardisation around screening. I'll talk a little bit about that. It's down further, but just to say that now with the Daughters of Charity, along with Tala University Hospital and Trinity College, we have just received funding from the government to set up a national memory clinic for people with Down syndrome and intellectual disability in Ireland. And we're very, very excited about that. I think it really is. The daughters have huge experience and built up a lot of skill in this area over many years. And I think sharing that now and building and addressing the unmet need that there is across the country. And while we have pockets of very good services like St. Michael's House and there's some areas in the West, it's very localised. Most people, if you're not attached to a service, you simply can't get a diagnosis. And this is just a little bit of data. What we have to understand is, back in the early 90s, when people were not talking about dementia or Alzheimer's disease, the Daughters of Charity hosted the first pilot project really looking at dementia in people with Down syndrome. Dr. Martin McLaughlin, who was the clinical director, and Mary Cosgrave and other people were involved. Many of you here may remember that. And this is just that we have continued to follow this cohort over time. And this is a telling story. Here you can see that the risk of developing dementia at 50 years was 23%. But when people came to 55 years, that risk increased to 45%. But when people came to 65 years, the risk increased to 88%. So this is a real issue for us. You can see here, looking at the lifetime prevalence of new onset seizure development, you nearly see a linear line between the development of dementia and the development of epilepsy. I think this is quite telling. And here you can see here the lifelong prevalence of depression. and how it's coinciding with dementia. Similar indeed to the general population, we're not sure if it is a prodromal for dementia or if it's part and parcel of dementia. We know that it very much coexists, and it is important that that is properly assessed and treated. There's been a lot of talk around mortality. The earlier studies around Alzheimer's disease, looking in people with Down syndrome, would have suggested that the duration of dementia was about 3 to 5 years. This is not what we're seeing clinically. This is not what we're seeing. And this is the data, again, looking at mortality over a 20-year period, drawn from the Daughters of Charity Service. And here you can see the median survival time, everything to the left of this line here, people have passed away. So a median survival time from 0 to 7 years. But what's really important to remember is that 50% of the population lived, some of them as long as 16, 17 years with dementia. And this is really, really important data, because this has major implications on how we organise services, the support that we need, and how we set up our organisations to respond. And the cost of this care we have got to really understand. We are seeing that people are surviving now at end stage and an advanced dementia for many, many years. In the workshops this afternoon, we're going to have a series of papers from frontline staff, from the Daughters of Charity Disability Support Service, who are going to talk about their experiences in supporting people for many years throughout the continuum of dementia. And I think, we have built up huge expertise around what a good life and a good death looks like. And hopefully you'll be able to join those workshops and presentations this afternoon. But we need a paradigm shift in healthcare, from managing and diagnosing to preempt and prevent. It's a bit like IDS tilde. It's extraordinary to me that despite this very high genetic predisposition to Alzheimer's disease, that people with Down syndrome have seldom been included in intervention studies or prevention trials. So again, we working with the Global Brain Health Institute at Trinity College and with other colleagues and with the daughters. This is Dr. Niamh McGlinchey, who did her PhD with us, who now is really embarking on a PREVENT programme for people with Down syndrome. We have launched the PREVENT programme in Europe and now in Ireland for the general population. But you had somebody like me knocking at the door saying, why aren't people with an intellectual disability included in this PREVENT trial? And I'm glad, and hopefully we'll be able to manage to get it off the ground. And Niamh is going to lead out on that. And this here is, again, as I said, the National Memory Clinic, which we are now setting up in partnership with the Daughters of Charity and the other organisations. When it comes to technology, and I thought I'd throw in a slide or two around technology because it's pretty pertinent to this conference and the mission of DOCTRID. What we found was that older adults with an intellectual disability, 35% of them had access to a computer, 75% of them had difficulty in using it, and 99% couldn't use social media or engines without assistance. So this is really important when we talk about barriers to communication. We have worked again with these are two students here, Robbie and Keila, who have one from computer science and one from the School of Engineering at Trinity. And this is Patrick, where we have developed a wayfinding app to support people with intellectual disability to navigate their communities. We have just got funding now from the government to trial this with clients at Stewart's Care Services, and hopefully to trial it beyond that organisation as well. So this is an exciting period for us. Just to say, and I'm not going to dwell on it very long, but Ireland have recently launched what's called the National Health Indicators for people, for the general population. And in 2013, they launched what was called the Positive Ageing Strategy. And that Positive Ageing Strategy very much focused on 4 real pillars. And that was enabling full participation of people and removing the barriers to participation of older people in the community, ensuring mental health and physical health and wellness as people aged, ensuring that people could age with confidence and security in their communities, and a series of cross-cutting objectives underpinned by research. And out of that study, what the Ireland launch, the government then launched, was called the health indicators for the general population. But you had somebody like me, again, knocking at the door saying, what about people with intellectual disability? Are these relevant? Do we need additional, etc.? So I was funded by the government, and we launched the Department of Health, just to highlight to people, have recently launched the first positive ageing indicators for people with an intellectual disability, and this is exciting. So it is all about having an impact. So, you know, it's not just about doing this research. It really is about translating this research now to make real change. So we have taken the data, we've developed the MOOC, we've developed the Physical Activity Leadership Programme, we've now developed the health indicators, we're working with Palliative Care Network around end of life and a large end of life study. We're now looking very much moving into the whole area of biomarkers and prevention. We've developed an online master's now and a master's in ageing and ID, working with organisations around really looking at person-centred planning and what that looks like. I've completed a review for the government looking really at cost and quality of life in residential services, and I'm glad to see my colleague here, Esther Murphy, Professor Esther Murphy, who really was one of the key people who worked with us on that report. And now we have set up the National Memory Clinic. So it is really about that movement of the research to make change at an organisational level. I'm really pleased that this, on behalf of the team that I work with at Trinity, that for this work, and there was one award given to Ireland last year, and that the intellectual disability work really received that award, which I think was really great because it was just one award for the country and that took in everybody else. Now I'm going to quickly move to the next presentation, which is Dr. Niamh Mulryan, who's the Clinical Director at the Dorset Charity, and she's going to do a presentation on life events and mental ill health in older adults. Thank you, Niamh.
Okay, you're all very welcome here today, and I hope the sun will keep on shining after this afternoon. It's unusual to have it this fine in Galway. Today I'm here to present about life events in older people with intellectual disabilities and the impact that can have on people, and what we as people who attend services, who work in services and provide support for people with ID can actually do to help. This work is based on a paper written by one of my colleagues, Laura Bond, who is part of the research team in IDS Tilda. Mary has already alluded to the IDS Tilda story, and the information that we are going to hear about today is largely from Wave 3, the most recent wave. And we're looking particularly at the measures of depression, anxiety, and life events. So first of all, we'd say, what is it that we need to do with this data? What are we looking for? Well, how often are people with intellectual disability exposed to life events? What life events are they? How do they affect their mental health? What is the longer impact of these? And what can services do to support people when these life events occur? There are many, many different life events that we can all experience, and it's part of the human condition. It's the price we have of being who we are. We all go through life, we have positive events, we have negative events, and we have to work with people, with our families, and I think to get through these things. Some can be stressful in a positive sense, some can be stressful in a very negative sense. So when we look at the array of life events they're ones that many people will have experienced here in the room, and as we get older in life, we accumulate more life events because, again, that is part of the human condition. So in this study, as part of IDS Tilda, a 20-item checklist was devised. It was devised from two existing checklists that have been used in intellectual disability research, and also based on information from Wave 1 data. And a consensus was reached as to the items that should be asked. What we realised very quickly was that the life events that people experienced were very different to people in the general population, and therefore the existing checklists that existed would not translate very well over. So we also asked people the level of stress that was related to each event, whether they had no stress, a little stress, or a lot of stress. We also asked people if they had a doctor's diagnosis of a nervous, emotional or psychiatric disorder. We asked them to self-rate their mental health. We asked about psychotropic medication. And we used two scales, the Glasgow Depression Scale and the Glasgow Anxiety Scale for measuring parameters of mental well-being. So the results, I'm not going to go into this in great detail. Nearly 600 people completed the questionnaire. The DOI I'll include on the last slide. So if you want to see about the logistic regression and the kind of the more in-depth discussion, that's available in the actual paper. The mean age of the group were nearly 60 years old, and the majority had ID in the moderate range, about half of the group altogether. So first of all, just looking at the prevalence of emotional and psychiatric disorders from wave 1 and wave 3. As Mary said, over 50% of people had a doctor's diagnosis of such a condition, which is very, very much higher than the general population when you compare it to the generic TILDA study. However, that said, about 3/4 of the people that were asked actually rated their mental health as being good, very good, or excellent. So while we're seeing a lot of psychomorbidity on testing and through the questionnaires, people themselves actually felt that they were doing pretty much okay, and only about 1/4 of people felt that was not the case. So looking at life events then, we asked people about, with the 20-item checklist, about the various life events that they may have experienced. Only 11% of people, nearly 12%, had not experienced a life event in the previous 12 months. Some people experienced up to 6, 7, 8 life events, which is an enormous number of experiences, be they positive or negative. They are still challenging for any of us. And if we just look at this slide for a second, this is just looking at the most frequent life events, and they are change of staff in their home, change of a key worker, death of a friend, a new resident moving into their home, or a change from their work or their day's service. And if we just pause and look at our own lives in the last 12 months, how many of these very frequent life events for people with intellectual disability have any of us experienced? I'm imagining that it will be very, very different to this, okay? And this is where, looking at people with intellectual disability and actually hearing their voices, and this is so important because it is not what people might think it is living in the general world as most of us here live in, okay? And all these events had varying degrees of stress, particularly relationship breakdowns and death. So, briefly looking at the results, people that were living in institution or campus-based settings experienced more life events. People that had a diagnosis of mental health disorder experienced more life events. Participants that had greater depressive symptomatology experienced more life events and greater stress. And more life events at wave 2 were associated with the initiation or increased dose of hypnotic or sedative medication and mood stabilizers at wave 3. So this is the kind of longer term impact. Now we can't apply causality because the association is there. So whether people move or start more medication because of a life event or whether it's the other way around, I can't say that based on the information that we have here, but there is a strong association. Okay, I suppose this is a slide that I'd like to see maybe more in presentations, the so what, who cares slide. Because we have this information now, so we know what's happening out there. We know that people with intellectual disability have very different lives, have very different experiences to those in the general population. Nearly 600 people took part in answering these questions. They had families, carers, staff members, all supporting them doing this. So there's been an enormous number of people involved in actually just gathering this bit of information for this presentation and for the paper that came from it. So it is really important. People have given time, people have been invested in this. And who cares? Well, we should all care. All of us, we're all here in the room for a particular reason. We're all here because we either attend services, we support somebody with an ID, or we research the situation for people with intellectual disability. So we should all care. So what can we do? Where's the translation of this? So now knowing better, we need to do better. So we need to do something within services that's actually going to make a difference for people. So first of all, security of living arrangement. Moving home, changing location of residence was one of the biggest life events that people experienced. So within services, what can we do? How can we future-proof environments so people can stay longer or stay throughout their life course in one place, surrounded by familiar people, be it their family if they're living at home, be it by carers, the sights, the smells, the sounds, having familiarity with place is so, so important. We need to have an evidence base to underpin these changes, and that data is gathering as we speak. We noticed that one of the big things was change of carers, change of staff. How do services become employers of choice? How do we ensure that while even in a healthy organisation there is a turnover of staff, that is inevitable? Are we losing staff? Are we losing staff because we don't care about them, because we're putting them in situations that maybe not where they can shine, not where they actually feel most comfortable? And how can we make sure that if somebody is supporting somebody, that they actually want to be there, that they enjoy that work, they feel valued? What staff initiatives within services can be initiated to actually help people, to make them feel that they, maybe it's a training thing, maybe there's training needs that we need to feel that if somebody that they're supporting, that the needs have changed, that maybe they feel unskilled and feel overwhelmed and unable to support that person. We need to have flexibility. Can we support people if they want to have kind of shorter working weeks, different working hours? And if that means that they can stay with the people that they're supporting for longer and feel valued in that role, well, looking at life events, that can cut down a lot of life events for people with intellectual disability. And again, this is sort of thinking beyond just the person and the services that we provide. We see that kind of loss of relationships, be it through separation, be it through death, are very important. Are all services providing counselling supports around relationships, around bereavement, about loss of health, loss of physical ability? What are we doing about that? It's something that everyone in this room is going to experience a change as the decades move on. We know this happens much more rapidly for people with intellectual disability. They do experience premature aging, and they will experience many of their peer group dying at a young age. They will also see their parents who they've lived with and they've been extremely closely tied to passing away also. How do we support that? What can we do within services? We can't stop people getting ill, we can't stop people dying, but we can certainly support and mitigate the effect on people with intellectual disability by making sure that we have good supports, that we have materials that are understandable, and these are the initiatives that we need to be doing on the ground to make this work out. How do we ensure that people that may have different communication styles actually can understand what we're talking about? We can have all these initiatives, but yet if we're not putting it in a manner and a form that people can understand, it's not going to really be very effective. So we need to enhance the communication possibilities and over between today and tomorrow, communication will be coming up again and again. And we also show that we are listening to people, that if they're telling us that they're experiencing a life event and they're stressed because of it, that we can be there, we can share the good times, but we can also share the bad times and the not so good times, and we can make a difference. So an exercising of choice, it's a whole other section of research my still is looking at choice. And so when people feel that they are active citizens in the world around them, that they have control, that they have power within their home and their situation, they feel more positive. Will this mitigate against stress if they experience a life event, if they actually feel that they are more in control of the outcome, that they are more in control of what happens during that flow of that particular event? That's something that we need to look into a bit more. And so many of the things that we're showing, I suppose, that there's much done, but an awful lot more to do. And it's kind of services are there to make sure that this work is translated and that the people that are receiving supports actually do so, and that we actually take all this information on board. So that's a take-home message, really. So we know now what people are experiencing, certainly in Ireland. I don't think it's probably that different in the US. I think it's probably very, very similar situations. And we just need to kind of maybe do better now that we know this information, and that it just doesn't become kind of a fusty paper sitting on a fusty shelf, or even kind of an electronic shelf at this stage, that it is actually enactioned and that is taken on board by people. So this work wouldn't have been possible without all those hundreds of people, be they people with intellectual disability, their supporters, the staff, carers and family members, and all the people behind the IDS Tilda project. Many of the people that took part in this were actually from the Daughters of Charity, and going through different waves, the ongoing support of the teams there is very much appreciated. So, thank you.